Good morning. It's a real pleasure. Is that too loud? Oh no, it's the music. It's a real pleasure and an honor to be invited. I want to thank Mr. Reagan and the entire InterSystems team. I'm going to drill a little bit into what Mr. Reagan talked about this morning, and actually the presentation on the Sovereign Wealth Fund is very relevant because the world population is facing a crisis in healthcare. And I'm going to drill a little bit into that. What is the cause of that crisis? Well, the first and most important source of the challenge for delivering healthcare is demography. It's the aging of the population. Now, interestingly, I did a little research on the flight here, and Europe and the US are quite a bit older as a percentage of the population and are right now experiencing extraordinary access problems to healthcare because of the aging of the population. Indonesia, only 6% of the population is currently over 65. That's a fairly small percentage. It's less than half the percentage in Europe and the United States. But with the aging of the population comes an extraordinary pressure on the delivery of healthcare. And the good news for Indonesia and for most of Asia is that there is time to figure out how to deliver care so that you don't end up in the same position that Europe and the United States are today. And that is, we are facing a massive crisis in the difference between the healthcare the population needs and the healthcare that we are able to deliver. When I was at the NHS in England, we did a little experiment. The health minister asked us, said, in 10 years, how many people will be required to deliver the health services to the population that we will have in 10 years? Currently, 12% of the workforce in England are healthcare workers. We calculated that 26% of the entire workforce would need to be working in healthcare to deliver the healthcare that the aging population needs. That's impossible. Right? It is not possible. There is only one solution to that problem, and that is we have to deliver healthcare completely differently. We have to make healthcare become a tech-enabled service. We can't continue to provide the most common delivery of the service provided in healthcare is a one-on-one interaction between a clinician and a patient. We have to move from one-to-one to one-to-many. Now, Mr. Reagan pointed out, and I agree with this prediction, that because of the shortage of people in healthcare compared to what our needs will be, we won't be losing jobs to AI, but we will have very, very different jobs. And so the good news is that right now we stand at an unprecedented time for change. But healthcare doesn't change very easily. And that's because people's lives are at stake in the delivery of healthcare. And so the challenge that we face is care 20 years from now, care 10 years from now, needs to become much more tech-enabled, but it needs to be safe, and it needs to be caring. It is fundamentally human. As Terry said, this is about individuals, licensed clinicians, making decisions and getting the technology to support those decisions. All of our workflows are going to be different. in order for this to happen. The population will get a lot of healthcare right on their phone. That's happening, but it's going to happen even more. A lot has been said about the importance of the biotech revolution. And I would say the biotech revolution has really over-delivered against expectations. If you look at what science has generated for therapies in the past 20, 30 years, I think it has overachieved what was expected of it. I mean, we have cures for genetic diseases. We have now over 40 cures for genetic diseases that didn't exist 20 years ago. GLP-1 agonists. We have a host of new cancer checkpoint inhibitors, a whole range of oncology therapies. All of that is great news for the people who are receiving that care, but all of that adds pressure to the delivery of care. We have so many more things to do for people than we had 20 years ago. And it's the same workforce, by and large, that has to deliver all those new things. The burden of illness, it's a famous economic term. What is the burden of illness? But actually, we don't calculate the burden of illness as the burden on the delivery system. We calculate it as an economic burden on the population. We really need to change how we think about burden of illness, and we need to calculate burden of illness not as a problem for economists and the government, but as a problem for the delivery system. Because that really it's the number of therapies we have times the population that needs those therapies that represents the gap between what we're able to provide and what we will provide. So all of that is background, and apologies, you may have already known all that, but I wanted to drive home the point that we're facing a really big challenge, a challenge that is going to require major change in the delivery of healthcare, changes that will be uncomfortable. So now I'm going to click the slide advancer, maybe. And I'm going to talk about, I only have 2 slides. I'm going to talk about the basics and then how we're going to think about how we select technologies in the future. So all information is digital. That is, I'm sure that's true for a lot of healthcare, but there is still a lot of healthcare in England, a lot of healthcare in the US that is not yet digital. None of the things that we want to do with AI are going to work unless we complete that process. Universal patient and clinician access to all records. This varies really a lot between countries. So some countries, your personal information is at a single site. It is not available at another site if you get care. There are several countries that have really solved this problem. I'll say the United States has not, though it's making a lot of progress recently. That is an essential step in the efficient delivery of healthcare, and InterSystems is the world leader in that interoperability space. Universal access to personalized advice on preventive services. So this is a very important thing. There are now, I'm counting, there are now 4 countries in the world where you can look on your phone and find your age-appropriate advice and whether or not you're up to date on vaccines and screening. Very important for everyone to have access to the information about themselves. So it's personalized, so they know, is there something specific that I could do to improve my health? All records available in a SDE, that's an abbreviation for Secure Data Environment. So technology has advanced to the point where it is now possible to put data in a data environment, keep it completely secure, but make it available for training AI models or research in therapeutics. This is a huge growth area right now and is very exciting. Digital triage. So the navigation in the health system, that should be an automated process. I'll tell you a little story about when I was at the NHS. We had a cyber incident, and there are 8 regions in the NHS in England, and each of them has their own triage center, so it's a call center. And the software at 2 of those centers went down because of a cyber incident. And so we had a natural experiment. And we could see in the 2 regions where the software went down, what happened in terms of triage. Interestingly, nothing happened, which indicates that human-based triage on the system that they use in England is so risk-averse that basically it sends people to go where they would have ended up anyway. Not very effective. There's a huge opportunity in digital triage. And then the last one is health therapeutics for mental health. So there are now dozens and dozens of randomized trials showing that with certain health conditions, like body dysmorphic disorder and others, actually a phone, a properly prepared bot on a phone can do better than a psychiatrist. Not because the bot is better than the psychiatrist, but because the interaction with the person is daily rather than the weekly or bi-weekly interaction with the psychiatrist or psychologist. These are what I call the basics. Now, the Minister of Health for England asked me to develop criteria for how we should spend money on health technology to deliver better care. And these are the criteria we came up with. They called them the Ferris 5. So we have to go after national priorities. That means common conditions, okay? We need to go after places where we're going to have big impact on population health. We need to reduce the friction for patients and providers, all the different transactions that are required to deliver care. We need to reduce the steps in those transactions. We need to reduce the steps in the process of the patient journey, similar to the friction, but the actual steps in the patient journey. And this is the hardest one. They need to be cash releasing. Let me just say a quick word about what cash releasing means. Healthcare is already chewing up an awful lot of the budget of most countries. And given the aging of the population, it is difficult to imagine how we're going to afford healthcare in the future. It was interesting. I once had dinner with Bill Gates. I was very, I'm name dropping, but I had a very interesting. I was asked to resolve a bet between him and someone else, and I had dinner with him, and he said, "You know, the problem with your industry in healthcare is that when you adopt technology, you get paid more to adopt that technology. When I adopt technology, I only adopt it if underneath the ceiling that I'm paid, I reduce my costs." We don't do that in healthcare. We don't adopt technology in order to reduce costs. But that is, in fact, what we must do. We need to lower the unit cost in the delivery of healthcare. And the way to do that is to adopt technologies which lower our unit cost. That is a tough bar. I've been told by a lot of technologists they would prefer to leave that criteria out. But I don't see a future for healthcare where we ignore the fact that our unit cost is far too high in the delivery of services. And then the last one is real-world evidence of the 4 points above. I say real-world evidence. We don't need randomized trials of this stuff. We need real-world evidence in the day-to-day management of the delivery of care. So let me just say that my only other slide is I see 4 big categories of technology for that will transform care. So I mentioned therapies, But I want to go to diagnostics, so service line technologies. Here's a great example of how technology is going to change care. It's also an example of how hard it is to create adoption. So I'll mention a few technologies, the technologies that I'm going to say I have no financial tie to. Let me just say that there's a software called Cognoa Health out of San Diego. And they use AI to analyze 2 3-minute videos of a 2-year-old child. So right around 2, the age of 2, is when children who will go on to develop autism first start presenting. And it can be very tricky to make the diagnosis. In many countries in the world, it takes 2 years on a waiting list to get to see a child neurologist who are qualified to decide whether or not that child has autism. This software, this AI software, analyzes 2 short videos of a child and has a 98% accuracy in diagnosing whether or not that child has autism. So why are there millions of children and millions of worried parents around the world waiting for that appointment with a specialist when there's technology that can just do this? And the reason why we have so many people waiting for this technology is that the technology isn't being adopted very quickly, okay? Because there is a barrier, and I call this barrier guild protectionism. And those are my colleagues. Those are the people who run the national societies for dermatologists or child neurologists or whatever it is. And they're worried about these technologies. And as Terry said, yes, there are hallucinations and biases in these technologies, but when you have access issues that mean people are waiting for care for 2 years, I'll take the risk of those biases and hallucinations, which, by the way, physicians have too, against those waits. Okay, because those 2 years are critical for children. I'm not going to go into the rest of these, but there are literally hundreds of ways, like stethoscopes, that will actually tell you what the valve area is, so you don't need to order a cardiac echo, or a home sleep monitor that is the size of a button, and you can tape it right here to your throat. It Bluetooths to your phone. You sleep in your own bed. Your phone reports the results in the morning to your pulmonologist, and an AI reads the diagnosis and sends it to you in real time. This should be over the counter. There's no safety issue associated with this. There are so many things that could lower the unit cost, improve the steps, and release cash so that we have the money available to pay for all the things we're going to need as our population ages. Let me get on to clinical decision support. This is my favorite because this is where things really change. So there is a technology that has taken the U.S. by storm. It's called open evidence, and it is basically doctors sign up for it free, and they're given advice. They can type in any question they want. But I'll tell you, I think InterSystems just leapt right over that because the IntelliCare that they just spoke about is embedding it right in the EHR. The open evidence solution is outside of the EHR and has interoperability challenges. This is, I really wish this was around when I was practicing. I recently stopped practicing. But 2 weeks ago, my daughter started medical school, and a lot of my friends said, "Why did you advise her to go into medicine? It's so terrible to be in medicine." And I said, no, actually, this is the beginning of a completely new era in medicine, an era in which it will be so much more exciting to practice medicine when the cognitive load is managed by, just as Terry said, is managed by the technology and the caring, the actual time with patients and advising them. That will be the job, and that is the best part of the job. Operations and administration. So I put some things up here, but I need to finish up. So I'll just say, this is the massive opportunity to lower overhead. So Nikolai Tangen is the CEO of the largest sovereign wealth fund in the world. It's the Norwegian Sovereign Wealth Fund. The Norwegian Sovereign Wealth Fund owns 1.3% of the entire world. And he has come out publicly and said, generative AI is going to reduce the overhead costs in every industry by 50%. 50%. So think about the overhead costs and how much we could spend on healthcare if we were spending less on the overhead and administrative costs, the transactions associated with healthcare. I'll just say in the US, where we spend about 13% on overhead, cutting that by 50% would pay for the care for every child in the United States for 50 years, as a point of comparison. So, huge opportunity with generative AI to reduce overhead from our operations and administration. And then I'll finish up with analytics and metrics. So this is the intelligence you get from having the availability of data. And I want to also say that one of the major problems in the delivery of healthcare throughout the world is that healthcare has lots of different services, which if we were in a true market-based system, we would use different payment methods for doing different things. So I'll give you an example. Preventive services should be paid for fee-for-service, because the more you deliver, the better off the patients are, as long as you're delivering accurately. Whereas trauma services are on the opposite extreme. They're really a utility. They're extremely expensive to maintain, but you have to maintain them. So you really need a capitated payment for a set of utility services. So healthcare includes both extremes and everything in between. But because it has been too complicated to administer the finances of healthcare according to each of the areas optimally, we haven't done it. So we often pick, the US picked on one side, picked a almost entirely fee-for-service, trying to move more into a capitated arrangement. On the other hand, the NHS in England has a capitated arrangement, and they are, because of limitations with that, moving a little bit more into fee-for-service. Interesting that the fact is that healthcare is complicated, and we should actually be customizing the payment method to the ideal payment method for that type of service. Economists generally say there are 5 types of services. We don't do that because it has been too administratively complicated to design. No more. It is not administratively complicated for an AI to generate the necessary categories and payment methods to operationalize a completely new way of financing healthcare, a way that will optimize in each vertical in healthcare the delivery of that service. That is coming. There are some early indications that payment schemes are moving in that direction. So I want to just finish by thanking you. the work that you're doing is absolutely critical to the future of the health of the populations you're serving. And I think it's an extraordinary time to be in this business. And it's an extraordinary time to be serving the people that we care for and love. And thank you very much.